Thank you for attending this month's complimentary webinar hosted by the American Academy of Craniofacial Pain. Today's webinar is PRF Applications and Techniques for TMD, presented by Dr. Daniel Klauer and moderated by Dr. Baba. Make sure to join us next month for the Key to Locking Out Lawsuits for Healthcare Professionals with Jamie Otto from Legally Mine. Our moderator this evening is Dr. Joseph Baba. Dr. Baba attained his undergraduate degree from the University of Kansas, and his doctorate of dental surgery was awarded in 1982 by the University of Missouri-Kansas City School of Dentistry. Research in the fields of craniofacial pain and sleep has rapidly increased over the last 20 years, so each year he completes more than 100 hours of continuing education through lectures, in hands-on and laboratory formats, and by completing residency and mini-residency programs. This ensures he is always providing his patients with state-of-the-art care that's grounded in deep background of experience. Helping people become free of craniofacial pain is his life's passion, which is why he holds a membership to the American Academy of Craniofacial Pain, the American Board of Craniofacial Dental Sleep Medicine, American Dental Association, Kansas Dental Association, and Wichita District Dental Society. Thank you for joining us tonight, Dr. Baba. If you wouldn't mind presenting Dr. Klauer.
All right. Once again, thanks for attending this seminar. You can read Dr. Klauer's CV. Basics of it is he graduated from Notre Dame and the Ohio State University for Dental School and has thousands of hours of continuing education in the areas of craniofacial pain and dental sleep medicine. But I want to make this introduction a little more personal. I met Dr. Klauer at one of Dr. Steve Olmos's mini residency classes roughly about 8 years ago. And what immediately caught my attention about Daniel was that he actually applied what he was learning. He would go to one session, come back, and have actually applied and treated patients in such a way that he was beginning to get results with them. There are 4 things that I want you to know about Dr. Klauer. He brings people together, and from that, he brings new ideas to light. And Dr. Klauer is willing to show people what he has done, how to implement all of those ideas, and in their own practices. He will easily tell you what has worked well and what has not worked well for him and for the others that he works with. He puts all of those characteristics into action on a daily basis. So please warmly welcome Dr. Daniel Klauer.
Thanks, Joe. I appreciate you giving the kind words, and obviously been a pleasure working with you and chatting with you and collaborating over the years. Well, welcome everyone. Thanks for being here. What is PRF? So Dr. Chakroun describes it as a second generation platelet concentrate that has growth factors in the form of fibrin membranes. So he was really the first to describe this in really the early 2000s. And so I got exposed to it through some of my oral surgeons were working with it. And then at the AADSM in San Antonio, Dr. Frank, I think it's Heinrich, described it at a course that Jameson was hosting. And he talked about how he used it in his practice. So kind of started to dive into it. And so I put together a bunch of articles and books that I've been exposed to, read, or compiled. And so JC will send you those links. But Dr. Chakroun's book on PRF in regenerative dentistry, goes into great details of this. But the basics of it, it's a second generation platelet concentrate having platelets and growth factors and fibrin membranes. And it's formed from the patient's own blood and free of anticoagulants or artificial modifiers. So PRP has anticoagulants and artificial modifiers, and requires more preparation, specific hood to do it under pressure and ventilation. Whereas with PRF, it does not require that. So it's described as a second generation. So the benefits of PRF are, and I kind of keep it basic of kind of how I'll go back and forth to how I talk to the patients about it and then the greater detail of it. So it speeds up and enhances the healing process, and it's capable of generating both soft tissue and bone. So you'll find a lot of oral surgeons or dentists that do surgery are using this a lot. Our oral surgeons are putting PRF plugs in wisdom tooth extraction sites to prevent postoperative calls for dry sockets and such. So a lot of applications for it. So the cons of PRF is there's no anticoagulants, so you got to move fast, and it requires a blood draw, centrifuge, and proper protocols. But really, it's not too labor intensive as you'll see here. So what's in the PRF? What's the good stuff? So we have our leukocytes, our cytokines, structural glycoproteins, transforming growth factor B1, platelet-derived growth factor, vascular endothelial growth factor, and thrombospondin. And that kind of happens post 7 days when you get that type of response with it. So these are kind of the big good things that are in there. And so what I tell patients is we're taking all the good stuff from your blood that happens when you have a normal injury, and we're just concentrating it and throwing it into a spot inside the jaw joint, around the jaw joint, that doesn't typically have a great blood supply and can have troubles healing. So we're taking all the good stuff and putting it right at the site of injury to enhance our healing capabilities, reduce pain, and have a longer lasting effect. So I'm going to kind of briefly go through some of these articles that really gave me the confidence to start doing this and using it as an adjunct. And again, I'm just going to show you what I've learned and why I've added it as an adjunct to our practice. At the end, we can talk about more specific indications. But again, I'm just kind of showing you a tool, and then it's up to you as a practitioner to decide, when it's appropriate, what diagnoses you want to use it with, and when you want to implement it in your practice. So this article talks about PRF as a treatment for painful TM joints. So it took 48 joints and 37 patients, and they injected 1 to 2 cc's of PRF in the superior joint space at 2-week intervals. And then they just recorded them using the visual analog scale. And so what it showed is that it showed significant reduction in pain in 8 weeks, and not too terribly surprising, but Wilks stage 4 and 5 seem to have the most significant response to pain versus earlier stages of jaw joint dysfunction. So the conclusion in this study, not the world's greatest study by any means, but a good preliminary study, shows that it exhibits long-term analgesic effects. So the article describes PRP in it. So it gives you a nice little background of that. So this is a good article if you have a patient that is kind of asking, well, what about this? I don't know about that. Give them this article and they can really read the history and evolution of PRP into PRF and concentrating the good growth factors and not having to use an anticoagulant. And so patients like that because it's just their blood. There's nothing else that's going in there. And really the greatest risk is them fainting, as I tell patients all the time. So on the left here, you'll see the features of PRP. You need an activator, you need an anticoagulant, and it's low on the white blood cells, and it does release growth factors, but it releases it rather fast, which is good for more acute injuries. So in regenerative medicine, you'll find the physicians using PRP for those more acute injuries, minor tears of ligaments and such. Whereas on the PRF side, it has a higher concentration of white blood cells and it's slower to release the growth factors, but it doesn't require an activator or an anticoagulant. And so PRF, again, described as the second generation PRP, and is developed really by Dr. I think it's Chakroun. I hope I'm pronouncing it right. But it's basically a low-speed centrifuge concept where they're spinning the blood at a really, really reduced speed. So this study, as the conclusion said earlier, that the PRF takes several days to require its positive physiological effect. And so it's typically we're getting a response longer than we would with PRP. So the results of this were comparable to using PRP in the joint, but did not require an arthroscopic intervention. So there's some good studies on showing PRP in conjunction with arthrocentesis. But what they're postulating here is that the PRF induces kind of a natural lavage of the synovial fluid. Sometimes what we find effective in the arthrocentesis, just cleaning out any of that joint debris that may be in there from the dysfunction. So it's really important to know there's no adverse effects in the study and no negative responses were seen from the patient. So complications were non-existent and patients tend to do pretty well. Responders were better with Wilks stage 4 and 5 derangements versus earlier derangements. And so at the top left there, you'll see all the prolonged release of cytokines and growth factors that play an important role in it. And the strength of this study is limited as there is no control group. But again, it's a preliminary study, and I think we'll see more and more of these coming out. This study shows the effects of PRP on fibrocartilage, bone, and repair in the temporomandibular joint. So it shows that it enhances regeneration of bone in degenerative osteoarthritis in rabbits. So it's showing that effect. And it shows that PRP has the potential effects on bone regeneration in induced severe degenerative changes. So they induced the degenerative changes in those rabbits, applied the PRP, and then followed them up clinically as well. So this study, again, is showing PRP in the superior joint space by ultrasound guided. It's really tough. I've tried it to try to visualize getting into the joint space with an ultrasound. It's kind of challenging. There's not a lot of real estate there. But this study did it, and it showed that patients with non-reducing disc displacement tended to do well with PRP. This study is showing a comparison of intra-articular injections of PRF versus hyaluronic acid following arthroscopy in the treatment of TMD. So it was comparing using PRF and receiving HA in patients with arthroscopy. And so what this study showed is that the PRF is more effective than the HA injections in patients with pain and advanced derangement of the temporomandibular joint. This study was looking at PRP with the treatment of arthrocentesis. And so there is significant reduction in pain and increased mouth opening compared to the control group. So the PRP injection for the treatment of reducible disc displacement of the TMJ is more effective than arthrocentesis. And when the disc is reducing, again, you probably don't see a lot of people doing arthrocentesis, but in this case, it was showing the PRP was more successful. I added these two articles from a journal as they go into great detail on basically the high-level view, definition, development, and the characteristics of the PRF. And then part 2 of the article talks about preparation, handling of it, and different benefits and limitations on really all aspects of dentistry. So it's a really cool read of all the different applications for it and go into much greater detail than we will with the TMD kind of indications and preparations for it. So you'll see here in the article, it talks about making that fibrin plug, cutting it up, how to prepare it, how to mix it with bone, and utilize it in many different facets of general dentistry. Another article here is showing the control trial of arthrocentesis with and without PRF. So I shared this with my oral surgeon that does our arthrocenteses, and we're having a conversation about maybe putting some PRF in there after he does an arthrocentesis, as this study showed that combining the injectable PRF with arthrocentesis gave a better outcome than the arthrocenteses alone. Additional PRF injections should be preferred for severe dysfunction, so maybe doing them longer after the arthrocenteses. This article is talking about the versatility of PRF versus, the PRP or just, straight blood injections, showing that the PRF seem to be more effective in patients with chronic recurrent dislocation to treat that. And then here it's showing PRF and HA in conjunction with arthrocenteses again. And then PRF in the treatment of hypermobility, showing that this could be an effective use for treating hypermobility by improving the integrity of the capsular and kind of ligamentous strains that we'll see in patients that are extremely hypermobile. So our osteopathic physician and I, Dr. Cantieri, are talking about utilizing this more on our Ehlers-Danlos patients as well. And then again, PRF in the management of internal derangement. And this study concluded that PRF is significantly effective for treating internal derangements. And again, all the studies I could grab the whole articles for without having to purchase them, I put them in a Dropbox folder so you guys can kind of go through those, decipher the quality of the study, and talk about it. But what's really interesting is a lot of these studies were really just doing the injections, and they weren't really talking about managing nasal breathing, managing apnea, using orthotics, using physical therapy, working with osteopathic physicians. So again, I look at this as a great tool. But for a lot of you who are doing a lot of different physical medicine modalities with your care, I would imagine that the results would be even better than just doing an injection alone. So kind of onto the meat and potatoes of it here is the injectable preparations, as described in these articles and in the text I've read, is the first one I read was about 700 RPMs for 3 minutes. So that's injectable PRF. And then I kind of messed around with these preparations to see the quality and how much of that buffy layer we get. Because really where you want to grab the PRF is right in here above the red blood cells. And that's kind of the area you want referred to as the buffy layer. And then advanced PRF is slowing down the speed and lengthening the time. And so the most recent study showed that the APRF, advanced injectable PRF. Gives you a little bit bigger of a buffy layer. And what's nice is if you disrupt the layer, you can respin it as long as you do it quick enough. And then I put KPRF for Klauer because that's what we utilize in our office with our centrifuge. We've been doing 1100 for 11 minutes. It tends to give us the broadest buffy layer that allows us to draw that up into a syringe. And I'll kind of show you how we do that here. So to encourage you to read, educate yourself, and then with your centrifuge, kind of figure out, how to get that best preparation. They're all going to be a little bit different. So what's the process? So this is kind of the step-by-step that we have for our clinical team. We'll wipe the arm with alcohol, place a tourniquet, use a butterfly needle, and we'll insert the test tube in the vacutainer to draw up 2 vials of blood, and then remove the tourniquet, have the gauze ready, and kind of get the blood draw done. We'll put in the centrifuge at 1100 RPMs for 11 minutes and make sure the patient is well cared for. So really the biggest risk that we've seen is having a patient faint from the blood draw or the injection. And so that's what I usually pose to the patients as the highest risk. Of course, we have an informed consent that we have the patient fill out before and explain it to them, the risks and potential complications that come from it, and really haven't had any pushback from patients. And we do want them off NSAIDs and anti-inflammatories. And then it's some complex patients, some HIV patients, patients with cancer. We just get a consult with their physician, again, kind of get the thumbs up from them before we do it just to be safe. And same with pregnant patients. We've just gotten medical consults. So from the injection standpoint, this is kind of the stuff we have out. And in the link that JC will send you, a lot of these slides we showed at the AACP meeting 2 weeks ago kind of show you the setup. And if an injection kit, if you want to purchase it, our medical supplier has put together kits that they can send out to people with all the injection stuff that we utilized at the AACP course for AACP members only. But basically, this is kind of what the tray setup is when the assistant comes into the room. You'll see the pen marker, gauze, needle, the butterfly needle, the vacutainers, test tube holders, medication, the hybicleans, and isopropyl alcohol to clean the surface. And so I flipped these over so you can see the actual syringe sizes that we use. We use a 3 cc syringe to drop the PRF in, 30 gauge 1 inch to do the injection, and then a 21 gauge 2 inch to draw it out of the test tube, as you'll see in a little bit here. And we got a Power Spin LX centrifuge, got on Amazon. I think it's like $300. And that works well for us. Now, if you're doing implant dentistry, regenerative dentistry things, and you're going to do a bunch of different preparations of PRF, like, more putty layers and stuff like that, then you probably would want to invest in a centrifuge that has a bunch of different presets. And Dr. Chakran's, he's got a centrifuge with programmable presets and everything. So that might be worth looking into. Here's that material list written out with all the different things that we have out in the room for the procedure. And really the techniques I learned from injecting in the joint were from Dr. Olmos in his course. And he gave me permission to use these slides because they worked for me in my brain when I learned it. Kind of illustrating how and feel you're getting into that superior joint space. You feel that resistance going through the capsule, and then you should feel pushback in most cases as you're going into the superior joint space from the posterior aspect. Now, it's interesting talking with some doctors of doing a anterior approach into the superior joint space in certain situations. And so I've tried that a couple times as well. But really, for those of you who are already doing joint injection and prolotherapy and different things, it's the same injection technique. You're just injecting a different substrate, so a different liquid, if you will. So you guys all know the proper angles for getting into the joint space. And then this picture on the far right is good just to show, remind yourself of all those capsular attachments and where you might want to put the solution to initiate that healing response. So in patients that are extremely tender, sensitive, I will do an auriculotemporal nerve block prior to kind of fishing around in that joint space. It really kind of depends on the individual, but I'd say probably, I don't know, half the time now, I'll just do it right as we're drawing the blood. And then, it'll set in as we're spinning the blood in the centrifuge. And so I grabbed these from Dr. McCarty. And so for the auriculotemporal nerve, they found it to be 10 to 13 millimeters inferior to the superior surface of the condyle and 1 to 2 millimeters posterior to the neck of the condyle. So I typically kind of go down that 10 to 13 millimeters, go and try to hit the backside of the neck of the condyle, slide over a little bit and deposit the solution in there prior to, if I'm going intra-articular and really trying to fill that joint space, especially if we have a severe arthritic situation. So the step-by-step here is step 1, draw the blood. Step 2, prepare the PRF and the centrifuge. Step 3, draw it out. And then 4, delivery. So actually injecting it to the site. So the blood draw, here's the inventory kind of list that you have to have out. And then we have a video here showing the actual blood draw procedure.
All right, we're applying the tourniquet. And then we are going to, we're just going to cleanse the area with alcohol. You want to try to wait at least 30 seconds for it to dry so that it doesn't sting the patient. We're using a 22 gauge butterfly needle, and this is the vacutainer, which Dre is going to connect. The patient's got her hand all taut, and then we're just going to, so we get a flashback, and then Dre attaches the vacutainer to the tube. You can relax your hand and just keep breathing. So we're going to fill 2 tubes to the black line on the vacutainer.
And what do you usually tell the patient prior to the appointment in terms of preparing for the blood draw?
We ask them to make sure that they're well hydrated, drinking water the night before and also the day of the appointment. That's good. And we're going to switch. You always want to wait until, for the vacutainers, you always want to wait until you've actually got a flashback before you attach that also. Otherwise you break the vacutainer seal and it doesn't work.
And you'll ask the patient previously where they have success.
Oh, yes. Yeah. I always ask the patient, do you have an arm that you prefer? I check typically both arms because sometimes just because that's the arm that they prefer, it doesn't necessarily mean I'm seeing something that day. That's good, Dre. Okay. And then Dre's going to grab me a 2x2. I'm gonna place here. Take the tourniquet off. Engage the safety. And then I'll hand that to Drea. We're going to apply pressure. You doing okay? Did a great job. Okay, I'm sorry. What was the question again?
No, just preparing the skin before, like a hot compress. If
yes.
the patient says it's tough, usually.
Our patient here today, she's got wonderful veins, so we didn't need to do that. But if a patient says that they're a hard stick, or and they traditionally will know if they're going to need something, we'll apply a warm compress, ask them to open the fist a couple times. And then also, well, can we go to her other arm here? And I'll show you, just as an example, you can see that you'd be able to draw from right there. It's elevated. Can you see that well? Mm-hmm. But often we're trying to go in the anacube area. The anacubal veins are the best typically, and she doesn't really have a visible one. So when you're palpating around, you'll feel a little spongy area there, even if you can't see it, and that's typically the best spot to go. But some patients, they don't have anything that you can get here, and so you're going to have to look out in this area.
So that was Heather, our nurse practitioner, who does most of the blood draws for us, and she's doing the injections too. So a good way to practice phlebotomy is really just kind of review the venipuncture sites and the selection that you want to do. And so as Heather was explaining, you want to go in the anacube area, and she found these slides and kind of listed choice 1, choice 2, choice 3, based on how anchored the veins are and the amount of pain that they would typically have and the least likely to bruise. And so, you can't go in the back of the hand. Those veins tend to roll a little bit more, and you kind of want to hold them steady so they don't roll on you and they're not attached and anchored as well. So what I did, before we had our nurse practitioner, I hired a phlebotomist to come to the office, and we just lined up like 5 or 6 patients and practiced on team members. And so I just got more comfortable doing it. My sister's a nurse. One day we had a lot of PRFs on the schedule, and Heather, our nurse practitioner, was gone. So I just hired my sister for the day. I never paid her though, but had her come over, and she just read a book and drew blood when needed for those PRF patients. So understanding your anatomy, having the right equipment, and you know what? You tell the patient, hey, we're going to get a stick. I'm going to try twice. And if we don't, we're going to get it. We're going to rehydrate you and have you come back. And have we gotten it every single time? No. I've had to send a couple patients home and tell them to come back, but usually it's because they're not hydrated well. And if they start early in the morning, usually can get it quite easily. So now, whenever you would do these PRF injections, you kind of are doing them in the areas where you could and would do Prolo, PRP, and stem cell if some people are doing that advanced. That's quite expensive, or just doing anesthetic injections. So really, it kind of depends on the scenario that you're doing. So in the centrifuge, in this particular spin, we did 2 vials of blood at 27.5 for 3 minutes.
So we have the 2 vials of blood here, and you might have to test your centrifuge to get the right separation, but ours is set on 27.5 for 3 minutes. And so when you load them in opposing each other, and close the lid, set it for 3 minutes, and it'll spin.
Then, test tubes will come out like that, and you'll draw the buffy layer into your syringe, grabbing it from each test tube.
So when it's done, we'll open it up. And the big thing is not to touch the wheel. Let it stop naturally. If you touch it early, it can disrupt the spin. And we learned that the hard way. So once it's done, we'll pull it out, and you'll be able to see the layers of separation. And that buffy layer is right before the red on the bottom. So we'll pull that out. And you can walk this to the room or draw it in the lab. We're going to draw this one in the lab just because we're here. So we take our Luer lock syringe, put a 21 gauge 2-inch needle on it to draw it up. It's thick enough bore, and also it'll allow us to get deep enough into that buffy layer. And so basically Heather's dropping it all the way down, and she's grabbing right at that layer. She'll pull up some out of that one, and then she'll grab some more out of the next one as well. And let's just show them where the needle is on this one. So kind of pull it out. There you go.
Let's see.
So she'll hold it there. And you need that 2-inch needle to get all the way down into there. And you got to try not to push fluid in, so go a little deeper. There you go. And if you start to pull up the red blood cells, you'll see it in the makeup. It'll start to drag up, so that's good. So now we got our PRF solution, and we will attach the 30 gauge 1-inch, since we're going the capsule and intra-articular into the jaw joint. So we'll just attach it back here, and then we'll go give the injection.
So Dr. Canteri was describing to me a tornado draw, basically putting the needle in, spinning it, and it'll pull up the bottommost part of that buffy layer from the red blood cells better. One of his colleagues did a study on it or described it to him. So as we were teaching the course, he was saying, if you spin that needle, you can get up even deeper to that red blood cell layer of that buffy layer. So then as we go for the injection, you just want to know what you're injecting. So in this particular case, we did the lateral capsule at the insertion into the zygomatic bone, and then also the condylar neck. And so we did that, and then went intra-articular as well for the injection.
So I'm going to clean the area with some Hibicleans, and gets any surface oil or makeup off. And I went ahead and marked right where I'm going to inject. You can draw up the entire joint if needed. So we'll use 3 cold sprays of some spray and stretch. 2, 3. Feel the pinch. Go right to that lateral head of the condyle. Doing okay?
Yeah.
Okay. You're doing great.
So
Right,
contacted
capsule
bone on both sites, so you kind of knew right where we
Go
were.
ahead and open for me down the last part here.
Had the patient open wide. And then my assistant typically is there kind of just helping scissor the mouth
3,
open, or we put a bite block in.
2, 1. Great. You did great.
In her case, we weren't trying to unlock her or anything. She had degenerative joint disease. And so typically a couple weeks into treatment is when we'll administer that. So, the possible indications, situations where we're finding we use them: degenerative arthritis, ligament laxity. If we have a tear, trying to do something before surgery. Capsulitis, if we're really not getting a great response or we're struggling to get someone over the hump. Anytime you otherwise would do prolo, you could consider it. We had a case yesterday. She's mid-ortho, Invisalign. She's moving to New York in 2 months, looking for help, but, limited with time. And so the orthodontist has been pretty thoughtful working with her, and she's getting worked up to improve her allergies and nasal congestion. Kind of in her situation, the best we could offer was some physical therapy and PRF to just buy her time and get her some relief as she, travels back out to New York. I've used it in edentulous patients when, an orthotic or a splint would be great for them, but they have no ridge or they can't keep it in, or they're just, super complex cases. We've offered it and utilized it in those scenarios. Had a really great response on like a 93-year-old who just, her joints were mutilated. And it was one of those, how involved do we get for making customized orthotics and all this stuff? So again, we're plugging and playing this and kind of learning where it's most effective and best use in our situation. But, in this case, this was a discal tear where actually one of the first cases I used it, patient fell on a treadmill, and you'll see in the MRI here, his disc kind of shattered into 3 pieces. And the oral surgeon was talking about taking the disc out, and patient's wife is a physician. I said, well, we could do orthotic therapy and, put some PRF in there, and you can always do surgery later. And so, sure enough, he did quite well. And, the disc, as the oral surgeon suspects, it'll probably just kind of disintegrate and get some thick fibrous tissue in there. But he's kind of doing well, almost a year and a half, almost 2 years now that he's post injections. I think we did 3 rounds on him. He's a 45-year-old man. And you can do it even in, 73-year-old females where you start to get some recortication of that bone. Now, have we seen this happen without PRF? Yes. Have we seen it happen without later? Yes. But I think it enhances it, accelerates it, and improves the treatment outcomes. And it's a great value add to the patient. Michael, a UPS driver, similar situation, degenerative joint disease, was given some options of surgery and wanted to go a more conservative route, and got a good response. Quality of life's improved, did find out he had apnea, got his nose fixed, did laser, did orthotics. So again, a lot went into this aside from the injections, but these are the type of cases and scenarios that we're choosing to utilize them. And to be honest, a lot of times I'm telling them, if we need to, we can do these PRF injections where we take your own blood. And they go, okay, well, if we do that, what's it going to cost? And for me, for patients in treatment, I don't charge. I tell them, as long as you don't charge me for your blood, if I want to do these injections, we'll go ahead and do them. Otherwise, I think we're, in the, $400 range for the injection if it's, not as part of a, more comprehensive treatment. So the codes that we do try to get reimbursement from for Prolo is M0076. Average amount is $205. If and when it gets reimbursed, again, I don't tell patients to anticipate anything. And then for PRF, PRP, P9020, and allowable amounts are seen to be at like 337. So these are some codes that you could use. But again, my insurance verbiage is insurance isn't very favorable. You'll find most the hospitals in our town, at least, I say St. Joe Hospital, Memorial, and Lakeland and Beacon, don't have any TMJ specialists. And I anticipate that's because they don't get good reimbursement. And if they can't get paid for a service, they tend to not do it. And so I'm left here to kind of treat all the patients that need that. And most of our patients come from physicians and dentists. So I'd say next steps for you all would be, read some articles, read the literature, read some of those studies, make sure you're comfortable with it, you're confident with it. And then you can go back and watch those videos and kind of follow those steps and see where it fits into your practice and into your repertoire. Again, a lot of different indications for it, I think. And, next step, once you know you're going to do it, is, market the ideas. So you could add a workshop explaining it to your patients. You can do a webinar to explain it, show 2 cases, and just talk about how great the patients did. In consults, I explain all the different things we do for TMD. I'll say, we do breathing, we do myofunctional therapy, we have orthotics appliances, we do physical therapy, we do referrals out, we have injections. And so I list a broad list of services, and I said, but your exam is going to dictate what you actually need for your problem. And there's, the saying is there's no treatment to sell until the patient owns their problem. And if you feel the patient isn't owning their problem, then, don't move on. And I typically say, I'm not aware of any dentists locally utilizing this, but plenty of physicians are doing it for other joints. And that usually kind of pacifies them to think that it's not like this wild, wild west type procedure or anything. So some workshops you can do is, you can do a workshop explaining the benefits of regenerative medicine and stuff. Workshop we have coming up that you guys are all welcome to listen into is a Buteyko breathing workshop. So we have group sessions rather than having patients come in individually. We do up to 20 attendees at a time, and we'll do these group session Buteyko workshops that our myofunctional therapists learn from Patrick McEwen. So there's a lot of different ways to talk about it, introduce it to your patient base. But I'd start first by doing it on some select patients. Family members are great, team members, and then kind of rolling it out to your patients as you see appropriate. And so with that, I'm going to turn the screen share off and be available to answer any questions that may come up or have come up. Now, like I said earlier, it's really the same injection techniques I learned from Dr. Olmos, and just using a different substrate in collaborating with really my osteopathic physician is the one who kind of pushed me to start doing these. So first question, do patients typically need multiple injections? How long does each injection last? So I think right now, I'd say under 50 years old, I've done 2 injections, usually 2 to 4 weeks apart, kind of like a prolo interval. And if they're doing better and they kind of seems like they need something more or they want it more, we'll do it again a third time. A doctor I know, I think he's in Arkansas, his protocol is 2 injections and then he adds a round of injections for each decade of life over 50. So 50 up to 50 years old, he does 2, 60s, he does 3, and he's doing them at 2 to 4 week intervals. So the studies range from doing it at 2 to 4 week intervals. And so understanding the inflammatory cascade and the healing cascade, like in Prolo, we tend to see that 2 to 4 week interval seems to be most appropriate and what providers are doing. And I think if we're controlling what potentially led to the dysfunction, the abnormal breathing, the bruxism, the high inflammatory diet, the apnea, if we're controlling those other factors, I don't really see the need to keep repeating these injections, just like with the other therapies we do. So if someone's got bad, disc displacement and we just laser, well, that's only going to take us so far if we're not controlling the other factors that are contributing to their dysfunction. So when is the next scheduled injection technique meeting? Right now at the AACP, we don't have anything on the books, but we did get a lot of positive, great feedback from the 2 courses in Dallas and South Bend. So I would anticipate that there's going to be another offering probably in the fall. We have the Academy meeting in August in Kentucky, but it looks like perhaps the fall or the winter, and maybe change up the location a little bit, maybe go West Coast or East Coast, as we were in South Bend, Indiana, and Dallas, Texas. I hope everybody found that, helpful and beneficial. Again, just sharing with you what I'm doing, and take it or leave it for what you want. By no means am I an expert at this, just kind of showing what I've done and what I've learned from utilizing these injections. First time I did injections was probably the day after I took a course with Dr. Olmos in 2013, I think, and kind of been using them in our practice since then. So it's a great modality to have, great resource for our patients, and just allows us to, help more patients and have some tools in our toolbox for those complex cases. If you guys have any feedback or questions, please, by all means, let me know. If anything I said was wrong or confusing, let me know. Like you all, I'm always constantly learning, refining, and enhancing my skills. So just have at it, let me know, and look forward to seeing you all in person soon, and hope everybody is well. Have a great night, everyone.
Thank you so much again, Dr. Klauer. We really appreciate you giving these webinars and donating your time to the AACP. Thank you all for attending tonight. Make sure to join us at 7 p.m. Central next month, April 14th, for our April complimentary webinar. Have a wonderful night.